I'm Byung-Moon Kim from Severance Hospital in Seoul. My topic is about rescue treatment in ICAS-related large vessel occlusion. Let me start to mention the difference between embolic and ICAS large vessel occlusion. Embolic occlusion developed by floating clot latching at the major branching site of normal artery. For example, ICA terminus, MCA bifurcation, a basilar artery tip. In contrast, ICAS in situ thrombocclusion developed by pre-existing plaque rupture causing in situ thrombocclusion, for example, ICA trunk, MCA trunk, basilar artery or basilar artery trunk. So ICAS LVO appears truncal type occlusion, and after removal of clot, fixed focal stenosis still remains. Again, in embolic occlusion, angiogram shows a normal appearing vessel after clot removal, like this. In contrast, ICAS large vessel occlusion leaves a fixed focal stenosis at trunk after clot removal, as mentioned multiple times in the previous lecture. Then, what's the problem in endovascular thrombectomy for ICAS LVO? That's repeat reocclusion. In my previous study, reocclusion after initial recanalization with endovascular thrombectomy occurred up to 77% of ICAS LVO. Multiple studies also indicated that instant reocclusion occurred in approximately 2/3 of ICAS LVO, which is usually refractory to repeat mechanical thrombectomy. Therefore, rescue treatment other than standard thrombectomy, I mean stent retrieval or contact aspiration thrombectomy, is required for resolving the problem, repeat reocclusion. Why does reocclusion happen? When ICAS LVO is detected, if it is tried with stent retrieval, contact aspiration, or both, initial recanalization is usually successful, but inflamed plaque still remains and causing plate aggregation and resulting in reocclusion. If only a small amount of clot formed, reocclusion can occur due to underlying severe degree of stenosis. From now on, I move on how to resolve repeat reocclusion. This is usually refractory to standard mechanical thrombectomy. Let me show you a typical case. Initial diffusion rate image shows a small area of impact in right side hemisphere. Angiogram shows right MR occlusion. Initial recanalization was achieved just after solitary first pass, single pass. Look at here. A focal stenosis still remains at right MR trunk. However, repeat reocclusion happened despite multiple passes of solitary stent. Intracranial, after intracranial glycoprotein 2B3A inhibitor, so-called GPI infusion, repeat reocclusion was resolved. These are next day MRA and diffusion rate imaging. Right MR is patent despite fixed focal stenosis still remains at M1 trunk. GPI resolved reocclusion in ICAS LVO. In this case, The patient presented with NIHS score of 8 and angiogram showed left M1 occlusion. Angiogram with solitaire in situ shows truncal type occlusion. You can see bifurcation areas is saved and all branches of left MCA are visualized with the stent retriever deployment. Initial recanalization was achieved after solitaire first pass, but repeat reocclusion happened. 3D reconstruction with solitaire in situ shows a focal stenosis at left M1 trunk with saving the MCA bifurcation. So this is M1 trunk occlusion. Right side image is just after solitaire single first pass, and left image is 5 minutes after solitaire retrieval. You can see recoiling of a focal truncal stenosis toward reocclusion. This reocclusion tendency did not respond to GPI infusion. So solitaire was detached as a rescue stenting. This is final angiogram. If reocclusion shows no response to GPI, rescue stenting with or without angioplasty may be helpful. This is a 3-day follow-up MR angio and diffusion rated image. The patient discharged with MRS1. 1-year follow-up angiogram shows improving status of the stenosis. In my report, reocclusion resolved with GPI infusion in 26.3% and with GPI plus rescue stenting in 52%. So glycoprotein infusion and or rescue stenting are effective for resolving the reocclusion in ICAS LVO. In multiple studies, recommend several rescue treatment. Dr. Kang reported the post-tryptophan use for resolving the reocclusion in ICAS LVO. Also, I reported single-center and multi-center Korean studies for stenting as a rescue treatment after failure of mechanical thrombectomy. In my studies, rescue stenting was effective and safe in patients with failed thrombectomy, which is mostly due to ICAS LVO. In my recent review, GPI and or rescue stenting are rescue treatment appropriate for ICAS LVO. For ICAS LVO is suspected. First-time stent reverse thrombectomy is recommended better than contact aspiration, as mentioned the immediately previous lecture. This flow chart shows the next step if reocclusion happened. As you can see, GPI infusion is recommended regardless of use of rescue stenting. A major concern about GPI infusion is possibly increased risk of symptomatic intracranial hemorrhage. How to decide to go or no go if reocclusion occurred? Let me show you a typical case to go. This patient presented with initial NIHS score of 19 and angiogram shows left ICA distal occlusion. Angiogram with solitaire inside to shows truncal type occlusion. You can see ICA terminus is saved. After solitary retrieval, you can see a very severe stenosis at the distal ICA with saving the ICA terminus. Repeated reocclusion happened. How to decide to go or no go? I obtained flat panel CT. Flat panel CT shows no remarkable enhancement. This is solitary stent. You can see no remarkable enhancement on flat panel CT. So I decided to go. And GPI was infused and solitaire was detached. This is the next day diffusion weighted MR, and this is a 12 months follow-up angiogram. The patient recovered well, and MS0 at 3 months and 1 year. How to decide to go or no go? If a flat panel CT after recanalization shows metallic density at basal ganglia. Metallic density is defined by 213 Hounsfield unit on flat panel CT. Follow-up MRI shows symptomatic basal ganglia hemorrhage with IVH. This case should be decided to no-go. Metallic density on flat panel CT at basal ganglia was strongly associated with symptomatic ICH in patients with recanalization success. If GPI is infused, the probability of symptomatic ICH may be more increased. Extent of hypoattenuation, contrast enhancement on flat panel CT is negatively associated with clinical outcome. Cutoff of flat panel CT aspect assessed by enhancement area instead of low density for malignant infarction is equal to less than 5. So if flat panel CT aspect for malignant infarct, flat panel CT aspect is less than 5, GPI infusion for resolving of reocclusion is likely futile and even harmful. So I'd like to strongly recommend flat panel CT to decide to go or no go. GPI with or without rescue stenting. Go further means GPI with or without rescue stenting. If metallic density on basal ganglia exists on flat panel CT, or if flat panel CT aspect score is equal to or less than 5, GPI infusion with or without stenting is likely futile or even harmful. Summarizing my talk, ICAS LVO can be differentiated from embolic before or during endovascular thrombectomy as lectured previously. What's the problem? Instant and delayed reocclusion. For resolving reocclusion, platelet inhibition and luminal gain are needed. Early recognition and optimal rescue strategy, GPI and or rescue stenting, are the keys to faster recanalization and keeping its patents, leading to better outcome. You can remember this figure. After initial recanalization, reocclusion occurred, First, plate inhibition by GPI infusion usually helpful. However, if very severe stenosis exists, rescue stenting for enough luminal gain may be needed. Also, reocclusion does not respond to GPI infusion, or reocclusion occurred after GPI infusion. Rescue stenting for enough luminal gain also may be helpful. Thank you for your attention.